Thank you. It's the Nisonger Center, by the way, with the Ohio State University Wexner Medical Center. So here we go. So my name is Zachary Christian. I'm a clinical behavior specialist here at the Nisonger Center. Scott Matlock's joined us today. He's one of our clinical psychologists who completes the risk assessments. So what we're going to briefly cover today is really just what are risk assessments. Um, what, let me move some stuff around on my screen so I can see. So before I jump into breaking down what goes into risk assessments for our individuals, I did want to briefly define sexual offending. So sexual offending is often conflated with inappropriate sexual behavior. And when you're working with someone, you might see either or, but sexual offending is typically reserved for rape, molestation, child pornography, sexual assault that leads to conviction. And so once somebody has been convicted, they typically have the label of a sex offender. And in their collateral, you might see sexual offending as like a target need or something. Inappropriate sexual behavior, however, is a little more nuanced. It's typically a lot of the same behaviors, but hasn't led to a conviction yet. And so, especially with adolescents or individuals with developmental disabilities, you might see the same types of offenses, but you only see inappropriate sexual behavior listed in their collateral or in their documentation. So for adolescents, I realize we're talking about multi-system youth today. You might be thinking about a case that you have in the back of your mind, and those types of things that you might be thinking about are someone who they're looking up weird videos on YouTube, like potty training videos, and you're like, what do I do with this? Or you're concerned because maybe they're peeking under bathroom stalls in the school at other students, right? These would be the types of things that would be red flags that you might want to get a risk assessment for. Or maybe they did go further and it's a youth molesting another child or something like that, right? Now, there is some nuance. A lot of times when we're working with youth and with individuals with developmental disabilities, a lot of times people have questions about like, well, can this person have a boyfriend or girlfriend? That wouldn't really rise to the level of needing a risk assessment. Or maybe this person's talking to strangers on Facebook, right? That's a risky behavior, but it wouldn't necessarily rise to needing a risk assessment. So a little bit of nuance there. So what is a risk assessment? So a risk assessment is lost my train of thought there, the word I wanted, psychological evaluation. There we go. That will help determine someone's level of risk to reoffend in a particular area. It doesn't necessarily have to be just a sexual risk assessment. Different psychologists and clinicians can look at specific areas based on their expertise. It could be fire setting, it could be physical assault. Today, we're looking specifically at sexual risk offending. There's a number of components that go into developing a risk assessment. First component is an intelligence test. Here at Nisonger, we use the WAIS-4. It's the Welsher Adult Intelligence Scale, 4th edition. It's used for individuals who are over 16 years old. So this provides a full scale IQ. The clinicians are going to look at different components of the test. So there's different subtests, and they're going to look at different components of it. The WAIS-4 is long, and so sometimes I'll admit it's hard to obtain client participation. The WISC-5 is for children for 6 to 16 years old. Now, with the WAIS, one thing that is interesting that is often helpful for team members working with individuals is that the different subtests, so there's several different categories, and if there's significant differences within those subcategories, it can really give direction to the team, even if it's not even related to reoffending or something. So a good example there would be that if someone has really high verbal reasoning, so they have really high receptive language, they're able to understand what we're saying, they have really high expressive language, right? So they're able to talk and communicate quite readily. But let's say they are really low in another subtest like processing speed. That could then aid the team in how they work with the individual. So example there would be if you're talking to the individual and they're nodding along, it seems like they're asking questions, they're repeating things back to you, and you're like, oh, they really understand what I'm saying. But then later on, it comes out like, maybe they didn't actually understand. Well, it might be their verbal processing is really high, but because that processing speed is lower, they're haven't actually caught up with what they're saying and what they're expressing. Working memory would be another really good example there. So somebody is really high in verbal processing, but really high in working memory. This leads to a lot of frustration for us when we're working with individuals who fall into this category, because you'll have a conversation with them, it seems like they really understand, but then an hour later, they don't have a recollection very much of the conversation. It could also indicate that somebody might have difficulties learning from their consequences. So that would also be another red flag there. So the next section in risk assessments are these more subjective measures, if you will. And so this is going to be a social history, a client interview, and interviews with other key people. So the social history is a brief history of an individual's initial offenses, the treatments that have been undertaken for that offense, if there's been any criminal conviction history, repeat offenses, any history of victimization in childhood. So we talk about what's happened to that individual. It's not as comprehensive if you're familiar with like a trauma timeline. The social history, not as comprehensive as the trauma timeline. Usually a couple paragraphs is really what ends up going into the risk assessment. The next section is the client interview. And so what we're looking for when we're interviewing the client is the insight that the individual might have into their own offenses, the degree that they empathize with their victims, and their attitudes towards treatment. And then the last real subjective measure is interviews with key people. So this is going to be people who know the individual really well and know information about the background. So that might be a parent or a guardian, other caregivers, maybe a close teacher or family members. People have been really around the individual. Then we move into more objective measures. And so these are clinical scales. So for sexual offending, we use a number of different clinical scales. We have the SORAG, SCAT-R, and the SONAR. And what's interesting with these clinical scales is as you put together information for the clinical scale, a lot of times there's an outcome of this individual based on this measure is at moderate risk to reoffend or high risk to reoffend. And you'll sometimes see that language in a risk assessment. So a little bit about these specific scales. The SORAG is the sex offender recidivism and the risk assessment for sex offender recidivism. So it looks at static and dynamic factors to determine someone's level of risk. I'll talk about static and dynamic factors in a moment. The SCAT-R is the social sexual knowledge and attitudes assessment tool. So this looks at an individual's knowledge of topics like consent, sexually transmitted diseases, dating and social norms. So for example, like when is it appropriate to kiss? When is it appropriate to have sex? The sonar looks at rape attitudes. So for example, one of the questions is on this specific scale is women go around wearing short skirts and tight tops are asking for trouble, right? And so you ask the client that and you get the response and you rate it. It also looks at child molestation attitudes. For example, question there is some children are old enough to have sex. You get the client's response and you rate it. And then it also looks at sexual self-regulation. So like seeing if the individual thinks they have a higher sex drive than other people. So with each individual, usually the scales, like not each clinical scale is used on each individual. Sometimes only a part of a scale is used. So maybe rape attitudes is used on the sonar, but not child molestation attitudes. And so it's tailored to the individual in that way. There's some other scales too, but this is a very brief overview of what those look like. So now I mentioned static and dynamic factors. So a static factor are things that don't change. When you're working with individuals, well, let me back up. So they don't change. This is going to include age of the first offense, number of offenses that have happened, severity of the offenses, if there's mental health comorbidity, history of substance abuse, all these things, when taken together, they're static factors, but let's say their first offense was when they were really young, they've had multiple offenses, they use substances, they have co-occurring mental health issues like maybe antisocial personality disorder. This person is almost always then going to score as a moderate risk to reoffend, just based on the static factors. Now, dynamic factors are things that change. So that's going to be significant relationships with youth. You think about how where they live, right? If you have someone in foster care, or maybe they're going into foster placement, maybe the home setting was really unstable. That's a dynamic factor, but then they move, they're in a new home, it's changed. The person's attitudes towards their offenses, that can change over time. I was working with someone, I'm currently working with this individual, and Scott, who's with us, has worked with him before me. Scott's done many interviews with this individual, and the last time we did a risk assessment, his attitude toward his offense had changed pretty significantly, and Scott made a remark to me. He's like, in 15 years, that's the first time I've heard him express any empathy. It was really positive, right? We hadn't seen a lot of change for a long time, and now this individual's attitude is starting to change. That's really positive. Therapy treatment progress, that's also going to be one of those dynamic factors. If they're in an employment or a school setting, how well they're doing there, again, that's going to be a dynamic factor. Now, one thing to consider is you'll also hear the terms protective factors and risk factors. And typically the dynamic factors are going to fall into a protective factor or a risk factor. And when you receive an assessment, you might hear reference to that. One thing that's interesting and often very difficult to navigate is some things that are often considered protective factors may become risk factors depending on the individual. And so that's where it's helpful to have a risk assessment to really determine what that might be. An example with that is I worked with an individual who he has developmental disabilities, going to an adult day program for vocational employment. And that employment is generally considered a protective factor. It's a positive thing in someone's life. However, it became apparent that he was using the other participants at the program to select his potential victims who he could sexually offend against. And at that point, employment was no longer a protective factor. In a lot of ways, it became a risk factor. So these things there's a lot of nuance a lot of times, and it gets muddied. You got to work through it. So at the end of a risk assessment, there's a lot of times some final recommendations, which what I should have started with was at the beginning when a clinician receives a risk assessment, usually in the referral, there's a reason for the referral. And those final recommendations often are based off of those initial questions. So for sexual offending, the reason in the referral might be something like, this individual was in a foster care placement and we had reports that there might have been some inappropriate sexual contact between this individual and some other foster siblings, right? We want to know, how can we support this individual? We want to know if this is an ongoing problem, something like that, right? And so then the final recommendations from the clinician will probably speak to the individual's supervision needs, maybe their need for a structured environment, need for ongoing counseling, sociosexual education, those types of things. And so that is the end of my didactic. Short and sweet.